Thank you very much, Neil, and thank you to everybody for giving me the opportunity to come here and talk today. I'm here talking on behalf of not only the Department of Neurosurgery, but also the Unit of Functional Neurosurgery. And those are my colleagues at the top over there. And you might ask yourself, what's functional neurosurgery? Well, if we think about traditional neurosurgery, this is what we think about. The anatomy of the brain or the spinal cord is distorted by multiple tumors, by trauma, by blood clots, and the role of the neurosurgeon is to try and restore an abnormal structure to a more normal structure, thus helping patients. It's technically demanding, it's challenging, we're often treating life-threatening illnesses, and it's a very rewarding part of neurosurgery. But my research interest and my subspecialist interest is about functional neurosurgery. When we talk about functional neurosurgery, the brain looks grossly normal, but it's not working the way it should. And we're performing a surgical intervention to have a positive change in function to affect the quality of life of our patients in a positive way. So the type of diseases that we're trying to treat with functional neurosurgery are different from the type of diseases that we treat with general or traditional neurosurgical techniques. And we're really talking about chronic debilitating neurological conditions. And if you like, the father or the example of all of these are movement disorders, specifically Parkinson's disease, dystonia, and tremor. And we're taking these techniques from movement disorders, where we're having tremendous successes, and trying to apply them to other disorders, such as patients with chronic pain syndromes, patients with episodic disorders, and Andrew's talked to you about epilepsy and the fact that we can stimulate the brain to try and help patients with epilepsy. Cluster headache, which is an episodic disorder where you have very severe pain. And we're also trying to see whether we can use these techniques to help patients with severe psychiatric disorders, such as severe obsessive compulsive disorder, depression, or perhaps even anorexia. So the main aim of this is to improve quality of life. A lot of general neurosurgery is about improving quality of life, but it's also life-saving. We very rarely save lives with functional neurosurgery, but we very often can improve quality of life. And because of this, we place a massive emphasis on safety. If I'm clipping an aneurysm, and a burst aneurysm has a mortality of 50%, then if I have an operative mortality of 3 or 4%, that's acceptable, given the 50% mortality. But people don't die of Parkinson's disease. So a 1% mortality when you're operating for Parkinson's disease is completely unacceptable. So you've heard the name Victor Horsley many times tonight, and you're going to hear it again. Victor Horsley was the world's first dedicated neurosurgeon, and he came up with this technique called the Stereotactic Technique. He never actually used it in humans, but he used it in primates. And it was a technique where you use a frame to guide navigation. He used it in primates, but we use it in humans now, with very, very high precision. He also performed the first open procedures to help patients with movement disorders such as choreoathetosis in the 1880s. He was a true pioneer. And the principle of the stereotactic technique is very much like the principles of cartography. If you have a map of London and you want to get from A to B, it's very difficult to describe that unless you place a grid on top of that map. And now you can say you want to go from square A1 to square D5, and everybody will understand what you're talking about. And these principles were transferred to human surgery by an American neurologist and neurosurgeon, Spiegel and Weisses. And the very first procedures they performed back in 1947 were to try and help patients with movement disorders and psychiatric disorders. So many people think of functional neurosurgery as a novel specialty. It isn't. A lot of the techniques we use are novel, but this goes back over half a century. Neuromodulation, by which we mean modulating the information flow through the brain, is a multidisciplinary effort. It's not just a neurosurgeon. It's a neurosurgeon working with neurologists, psychiatrists, the family doctors, specialist nurses, physiotherapists, speech and language therapists, assessing the needs not only of the patient, but also of the carers of that patient and the whole family. We mentioned that these diseases are chronic neurological conditions, and the diseases affect not only patients but families. And we have to approach patients together with their carers and their families. This is the most common technique used today, called deep brain stimulation. What this involves is a pacemaker for the brain, essentially, connected to a very thin electrode about the size of a spaghetti that's placed with extreme precision, submillimetric precision, within deep areas of the brain. And here we have some diagrams to show how information flows from the surface of the brain through to deep-seated structures in parallel loops, and the information is fed back to the surface of the brain so that the brain can do things with it. And we've got a bit of an idea of what the brain actually does, and neuroscientists are realizing that the main function of the brain is that the brain is an organ of prediction. It predicts what you're going to do, both in terms of movement, both in terms of your internal mood, and in terms of thought. And in certain diseases, like Parkinson's disease, you get disruption of this information flow because of the loss of vital cells, and you can see overactivity in certain nuclei deep within the brain. And by placing this electrode precisely within these different nuclei, we can affect how the brain deals with information. We cannot restore normality, but we can restore a degree of normality that gives patients very good improvements. So this is a patient who's undergoing surgery awake. You can see that the patient has Parkinson's disease.
You see what I'm doing up here?
She has all the cardinal signs: tremor, bradykinesia, by which we mean slowness of movement, rigidity. And we have the neurology team with her.
Can you try to do that
And
now?
she couldn't tolerate drugs. Every time she took the Parkinsonian drugs, the dopaminergic drugs, she became nauseated and vomited. And after we place the electrode within the brain and pass a very small electrical current, as we turn the stimulation up, here you can see the voltage being turned up, you can see the stiffness disappear. You can see the tremors gone and the rigidity is better. It really is instantaneous gratification, and from a surgical point of view, it's a really rewarding thing. The problem is not all patients can tolerate undergoing surgery under local anesthetic. It's tough, it's difficult. Children can't undergo surgery under local anesthetic easily, and they suffer from diseases like dystonia. And some people's movement disorder are so severe that we can't get them to lie flat on a bed to have the operation. So one of the things that we've developed, and you've heard about the iMRI scanner, our theatre, where we also have an MRI scan in the same room, is using not the patient's symptoms during surgery to guide us to the right spot, but the patient's own anatomy that we can define on the MRI scanner, and not only define these deep-seated nuclei within the brain, but also define where our little electrode ends up. And we can use the MRI scanner to guide us, and because of that, we can perform a general anesthetic. So we've heard of other specialties going from general anesthetic to local, but in my specialty, we're going from local to general anesthetic. And because we do that because we think it's better for patients, because patients don't have to stop their medication prior to surgery, which is a tough thing to do. It's less traumatic for patients to go through that experience. Overall, patients have a smoother post-operative recovery. And if we look at the results, if we look at the local anesthetic patients, where the improvement is how much this bar decreases, we see that under general anesthesia, we're getting even bigger improvements. So not only have we changed our techniques to make things better for patient comfort, we're also getting better improvement in the clinical outcome. Also, it gives us a shorter operative time, which means we can provide our therapy to more patients, which is also an important thing to consider. We've talked about safety. And the problem of getting an electrode deep within the brain, whether it's for recording for epilepsy or putting an electrode to try and help with a movement disorder, is we have to navigate this network of blood vessels. And mind you, that's just the arteries. There are veins there as well. And we have to get our electrode to the right spot within the brain without damaging these, because if we damage these, it can cause a bleed, it can cause a stroke, or threaten our patient's life. And we published a paper a few years ago showing that if we looked at the hemorrhages within the brain, and the most important hemorrhage are those hemorrhages that cause death or long-term neurological disability, when we were using the image-verified approach, we were supposed to get 7 bleeds causing death or disability if we had the same ratio as other techniques. But in fact, we saw 0. So this is not only good in terms of operative time, in terms of operative outcome, but also in terms of safety. And we're very proud that we've operated on over 700 patients over the last 12 years without a single patient having a bleed that caused a stroke or caused death.
What did you have for lunch for today?
This is a movement disorder called dystonia.
Fish sandwich and chocolate.
You can see that it's very incapacitating.
Is the night mail crossing the border, bringing the cheque and the postal order, letters to the rich, letters to the poor.
You write as much as you can.
She has something called torticollis, which is overactivity in the muscles of the neck, which is a painful thing to have.
Okay.
The rainbow
This is a week
passage.
after deep brain stimulation.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colours. These take the shape of a long, round arch with its path high above and its two ends apparently beyond the horizon.
You can see that the abnormal activity in the neck muscles is a lot better. Now, deep brain stimulation is not a cure. We do not change the pathology within the brain, the abnormality within the brain. So, for example, in patients with Parkinson's disease, we don't stop the degeneration, but we have a further tool that allows us to not only increase medication, but increase the stimulation as the years go by. But dystonia is not a degenerative condition, and therefore this is something that's not a cure, but we're hiding the symptoms very effectively for the rest of the patient's life. We're very fortunate to have an excellent service in terms of outcomes and in terms of safety. And in fact, some of our publications have received citations of being a new benchmark internationally for safety and efficacy within the world of surgery for Parkinson's disease. And our outcomes are not just good at 1 year after surgery, but even 5 to 8 years after surgery, we're still seeing benefit after the operation. So these aren't just temporary improvements. And as a result, the number of patients that we're operating on is increasing exponentially. And these are lifelong therapies. We don't just perform the surgery and the patient never comes to see us again. These batteries need tweaking. They need changing every 5 or 6 years. And therefore, we're having to deal with the replacement or maintenance of these systems. We now have over 700 patients in the community who we actively follow up as we go along. We're approaching 100 new patients a year, hopefully 150 by next year. So the number of patients out there who are reliant on our service is quickly going to be over 1,000. This is just a bit of the research that we do. At the moment, the commercially available deep brain stimulation devices provide constant pulses of electricity. What we do in the week after surgery in some patients who want to participate in research is that we don't connect those leads directly to the pacemaker. We bring them out through the skin for a week and we record the electrical activity deep within the brain. And because we've been able to do that, we now know what sort of signals are associated with the symptoms of Parkinson's disease. And instead of delivering a continuous DBS signal, we've said, let's give an adaptive DBS signal. In other words, we'll only give a pulse when we detect that abnormal activity, then we'll stop stimulating for a few microseconds and only start the stimulation again when the abnormal electrical activity is detected. And the patient doesn't know whether we're giving one or the other, and the neurologist who's assessing the patient doesn't know whether we're giving one or the other. And what we found to our delight is that we had an improvement in the scores when we give the continuous DBS, but we had an even further improvement when we're giving this adaptive DBS. And what this means is we can achieve more with less, because the amount of electrical activity we have to deliver is only 50%, which means the batteries will last twice as long. So we hope that this will be commercialized in the years to come in order to give even better outcomes with better longevity of battery life in our patients. It's not just movement disorders. We're taking this technique and we're trying to adapt that to other conditions. And one condition is called cluster headache. And research that was done at Queen Square many years ago showed that during a cluster headache attack, you get an overactivity in a part of the brain called the ventral tegmental area. This is part of a family of diseases called the autonomic cephalalgias, and it's often called the suicide headache because the attacks are so severe that they often drive patients to committing suicide. We have one patient who has 3 children who says going through labor is nothing compared to one of these attacks, and she has 5 or 6 attacks a day. This is a patient who took a shotgun to his own eye to try and get rid of the pain. You cannot imagine how much these patients suffer. Apart from the pain, you get autonomic symptoms like a redness or a tearing or a blockage of the nose. And we can often manage these by medical means, and I work very closely with the neurologists here, including Dr. Matharu. But some patients are refractory, and the medication doesn't touch or doesn't give enough improvement from symptoms. And what we've tried to do is place an electrode in this part of the brain to try and suppress that overactivity that's associated with cluster headache. And this is a result from 21 patients. We've had no surgical morbidity or mortality, and we're submitting this for publication soon. And this is what is called the headache load, which is the severity of the headaches times the frequency times the duration. And what we've seen is a significant reduction in that, which goes up to the last follow-up at over 4 years. So there's a significant improvement in the quality of life of these patients. We've talked about these circuits that go through the brain. And these circuits don't just subserve movement. They're not the circuits there that just make us move. These circuits also give us our thoughts. They create our thoughts. They create our emotions. We are the sum total of our brains. And because we've had these successes with movement disorders, neurosurgeons around the world are exploring whether we can use these same techniques to help patients with disorders of mood, depression, disorders of mentation, obsessive-compulsive disorder, depression. And in bold here, you can see the different types of diseases that we've treated over the last few years here at Queen Square. This is a plan for the future, and I'll speak a bit about that later. So Tourette syndrome is a condition that causes patients to exhibit an urge to perform a stereotypical movement, either a grunt or an expletive word, or these stereotypical movements that you can see here. This patient is Portuguese, and we flew out to help the neurosurgeon in Portugal do the first DBS for Tourette syndrome in Portugal. And he had hit his chin so many times that he'd essentially bruised his chin to maceration. At one point, the bone was showing. And this is him a year after surgery. And the examiner is asking him to do the tick, and if your Tourette's is very severe, then you can't stop ticking. This is 4 years after surgery. So after a few promising procedures which were done in an open label fashion, we wanted to have some good scientific evidence that this wasn't just a placebo response. Doing a brain operation can elicit a big placebo response. So we designed a trial, which has just been published in Lancet Neurology, where we compared the severity of the disease when the device was on with the severity of the disease when the device was off, without the patient knowing whether it was on or off, and without the psychiatrist knowing whether the device was on or off. And indeed, there was a significant improvement when the device was on. And in an open label fashion, there was an even further improvement in the tic score. We're also using DBS to try and help patients with severe refractory obsessive-compulsive disorder. We've obtained funding for 6 patients from the MRC. These are the worst affected patients in the UK. One of our patients had been in hospital for about 4 or 5 years before having the surgery. Her OCD was so bad that she would not drink, because if she drank, she'd have to go to the bathroom, and if she went to the bathroom, it was a 6-hour ritual afterwards to clean herself. Defecating would be followed by an 8-hour ritual. Showering was a 14-hour ritual. You couldn't touch her, you couldn't touch anything inside her room. It took her 2 hours to get from the corridor to the examination couch when she came to see us in outpatients. This was completely life-threatening. She's now independent. She's left the psychiatric institution, left her halfway house, now has a boyfriend, went traveling in Europe. She'll shake you by the hand, and she's working as a volunteer. And the initial improvements in the Y-box score, that's the severity of the obsessions, has decreased in all 5 patients that we've implanted so far, and we've performed surgery on a 6th patient in the last few weeks, and we hope that we continue to get such improvements in these patients. This is also a blinded trial. The patients don't know whether they've been switched on or off, so we'll get some high-quality evidence from this. That's just an email that I received from one of the fathers of the other patients. Because these diseases that affect our mentation affect these circuits, there are similarities between different diseases. And anorexia nervosa has a lot of similarities in some patients to OCD. It can almost be seen as an obsession about body image and a compulsion about feeding behavior. So we've now put together a study group with 8 different eating disorder psychiatric units, very interested in referring patients for consideration of surgery. And I hope that this time, in 4 or 5 years' time, I'll be able to tell you that we have positive results with what is a mortal disease. 15% of patients with severe anorexia die from it. So in conclusion, the neural circuitry that subserves our movement is similar to that subserves our emotions and our thoughts. This success that we've had with neuromodulation in helping patients with movement disorders is driving an exploration of seeing whether we can help patients with psychiatric disorders. Selecting patients is essential to obtain a good outcome, and that all my surgical colleagues will tell you that's the same with their own super specialties. And neuromodulation is driven by a desire to help individuals and groups. This isn't experimentation for the sake of experimentation. This is trying to help patients with severe diseases that are affecting their quality of life and the quality of life of their families. Yet it still provides a unique opportunity to perform invasive recordings in the human brain in an ethical fashion. And this advances our knowledge of how this 1.5 kilos of grey mushy stuff defines who we are. So an expansion resources at Queen Square will allow us to provide more timely DBS therapies. At the moment, the waiting list for my surgeries is over 7 months, and the waiting list to see me in clinic is about 9 months. It's not acceptable. We need to increase this. We have a therapy that works. We want to be able to deliver this to more patients. We have 2 surgeons recently employed a 3rd consultant surgeon, and the resources that the Brain Appeal will provide for us will help us get these therapies to the patients and families who deserve them. So thank you very much, and on behalf of all the people in the unit, I'd like to thank you all.